Hi there, everyone. Welcome. Thank you for joining us today. Sorry for those small technical difficulties. I think this is the first time my whole Zoom froze before I started a webinar, which is a surprise because we've been doing these for 3 years. Thank you so much for joining us today for a next installment in our COVID-19 series. My name is Krishnan. I'm the director of the Institute for Science and Policy, a project here at the Denver Museum of Nature and Science. And I'm thrilled to be bringing you what is, I think, episode number 35 in COVID-19 series that we've been doing in partnership with the Colorado School of Public Health. A huge thank you to them for this long-standing collaboration and the opportunity to bring you this really thoughtful and informed talks. 3 years we've been living with COVID-19. I think it was March 11th that the World Health Organization declared it a global pandemic. March 13th here in Colorado holds a lot of significance for many of us. We saw our government functions start to shut down. We saw many of our offices close. I know many of us went home on March 13th, really scared and looking forward to understanding what was happening with this pandemic. So here we are 3 years later, and we decided to bring you some really thoughtful public health experts. We're going to do a little bit of that reflective retrospective on where we've come in the past 3 years and what does that path look forward to us. As our audience, thank you so much for tuning in. I think you heard Nicole at the beginning, if you joined us a little early, asking you to go ahead and open that chat feature. Share with us any questions that you have throughout the program. I think many of you know that we get a ton of questions, and I really do my best to incorporate some of those themes and questions into our conversation today. I just want to say thank you very much for being engaged and submitting those in advance, and apologies if we do not get to your specific question. I do want to go ahead and bring my guests on today and say welcome and good afternoon to them. We have 3 really great people joining us. We have Dr. Rachel Herlihy. She is our state epidemiologist here in Colorado. She works for the Colorado Department of Public Health and the Environment, where she leads our COVID-19 surveillance, case investigation, and outbreak response activities. Good morning, Rachel, or afternoon. I'm so used to doing these in the morning.
And thank you for having me.
Great to see you again. We also have Dr. Krishnan. He's an Associate Vice Chancellor for Population Health Science and a Professor of Medicine and Public Health at the University of Illinois, Chicago. Dr. Krishnan studies new treatment strategies for COVID, including long COVID, which we will talk about today. And it's definitely afternoon for him. Hi, Dr. Krishnan. How are you doing today?
Wonderful. Thanks so much for having me.
Great. Thank you for being here. And many of you know this other person as well. It is our esteemed friend and longstanding partner, Dr. John Samet. Dr. Samet is a pulmonary physician and epidemiologist. He is the dean of the Colorado School of Public Health. His research is very extensive, but also focuses on public health impacts from inhaled pollutants, chronic disease prevention, and just global health in general. John, thank you always for being here and being this partner. How are you doing today?
Good, Kristen. It's nice to be here when we're not worried about how high the epidemic curve may go. So
absolutely. Yeah. Well, great. Well, John, why don't I start with you? Why don't you kind of, for our audience, set that stage a little bit, looking back at kind of COVID-19 over the past 3 years, some of those cases and hospitalizations that we've both seen globally and here in Colorado. Why don't you just give us a little stage setting and then we'll head into some conversation.
Okay. I think, Nicole, if we could go ahead with my 2 slides, what I'm going to do is just remind us of what happened over the last 3 years. And as Kristen noted, March 13th was an important day on this campus. It's when the Chancellor, Don Elliman, sent out a note saying that we would be going to remote operations. And so we did on Monday, the 16th. So this date will stick with me. Just as a reminder of where we started and what we have come to, here are WHO figures showing the estimated number of cases by WHO region. For those of you who don't know the regions, the Western Pacific, which is lighting up towards the end, that includes China, which of course is having now, because of its policies, a very late surge after relaxing the zero COVID policy that they had in place before. And you can see the tragedy of the millions of deaths in the black line that we have sustained. So we've had our ups and downs. And if we go on to the next slide, we'll look at Colorado particularly. And this is patients hospitalized for confirmed COVID-19 going back to the start. And I think those of us who have tracked this closely will remember with I think, a lack of fondness, these peaks that had us so worried over time as we came up to as many as 1,800 Coloradans hospitalized with COVID-19. We certainly, in terms of assuring healthcare capacity that being available, did not want to get over the approximate 2,000 mark. And as you can see, we flirted with that very alarming level on several occasions. And as you go through this, you can see the surges that we've sustained. You can see that later on, as we had vaccination, and with Omicron, we had a surge of cases and a rise in hospitalizations, but to nowhere near the levels that we experienced earlier, for example, with the Delta variant. So again, we've had our ups and downs. We've brought into play a variety of measures to control the pandemic, including that initial phase when we were stay at home. So we are now in a different phase. But if you look out to the end, and I suspect Rachel will comment, there are still people hospitalized with COVID-19, and that number has been roughly around 200 over the last several months. So we would like to think that the pandemic is over in Colorado. It isn't, and clearly we've gone on to a new phase, though, at the 3-year mark, and one that feels far less scary than on March 13th, 2020. So with that, Kristen, back to you.
Great. Thanks, John. Yeah, Rachel, I want to turn to you. This idea of flattening the curve, right, is a very common vernacular now in many of our vocabulary, and the idea of bringing down those peaks. And we just saw those peaks and troughs in John's slide, you know, as you were here responding to that in our state over the past 3 years. Maybe start with, like, how has our response changed from those early days to where we are now, and why, right? What are some of those things that we've done that you've reflected on over the past 3 years?
Yeah, absolutely. So as John described, really since the beginning of the response, our hospital capacity has really been guiding our response, you know, wanting to ensure that we had sufficient healthcare capacity available to Coloradans. And that was whether you needed a hospital bed for COVID-19 or because you were in a car accident or had a heart attack. We wanted Coloradans to have access to the healthcare they needed. And so as John described, that was really our guiding force, and really a lot of the effort that we put into modeling and trying to project what the course of the pandemic was going to look like here in Colorado. And as you described, Kristen, so we obviously saw a very dramatic shift in the tools in our toolbox to respond to the pandemic from the very beginning, where individuals were staying home. We were still learning about masks. And then obviously a vaccine became available, and we saw much greater levels of immunity. And as time went on, we also saw the virus change, right? So not only did we change, our immune systems changed. We had been exposed to vaccine multiple times. We had been exposed to infections over time, so much higher levels of immunity. But the virus changed too. So we saw the virus emerge, become more transmissible, so more easily spread from person to person, but resulting in less severe disease. And then honestly, the next really important change that we saw in the evolution of our response was the introduction of effective treatments. So a treatment that could now dramatically change the course of individuals who had access to that treatment and got that treatment in preventing hospitalization rates. So some of the data that we know about Paxlovid is that somewhere between 50 and 80% of hospitalizations can be prevented for individuals that receive that treatment early. So really dramatic shifts that really adjusted how we were responding and the guidance that we were providing to Coloradans, and same, of course, across the country.
Thank you. And Jerry, I want to bring you into this, and I don't know whether you want to answer this or Rachel, but an audience had asked, and you just brought up Paxlovid, about the rebound effect of Paxlovid. I don't know if either one of you want to take that on, and what are we seeing in regards there?
Sure, I can start, and perhaps others can add to this. I think that again, we're still learning how best to manage the infectious disease. And I have to say that Paxlovid has been a game changer in most cases. We have really dramatically shifted the curve towards less severe disease. What we are seeing, though, is that there are some people that tend to get sick once they finish the Paxlovid, and we're not entirely sure what that's about. There's some theories that perhaps there are areas of the body where the virus hasn't been completely controlled, and so there are areas that are almost sequestered, and maybe we need a longer course of Paxlovid. In other cases, it seems like the immune system, for some reason, tends to get activated and actually creates trouble. It's almost like the body's attacking itself. There's an autoimmune phenomenon that's happening. So there's a lot of theories right now, but I would say, if you look at the big picture, Paxlovid is a good thing in people who need it. It's dramatically shifted how sick people have gotten, really prevented a lot of hospitalizations that would have otherwise occurred. And now we're starting to understand what else should we be doing. Should we be thinking about a longer course of Paxlovid? Are there other treatments, and so on? So I'll turn this over to Rachel and maybe John, if they'd like to add.
I think that was a fantastic summary. I think I would just point out that rebound also occurs in individuals who never received treatment. So that phenomenon is also possible. And then it's been seen with molnupiravir and other treatments as well. So it does seem to be something that can happen, and certainly don't want it to be a reason that people choose to not receive treatment. That would obviously be, I think, very detrimental if people choose to not receive treatment because of this potential of rare rebound occurring.
Jerry, talk to me. You're in Chicago. How have you seen the response change, either in the public health field or through your own work that you've been doing?
Sure, absolutely. I think that the state of Illinois, in many perspectives, is similar to the state of Colorado. We have urban centers, we have semi-urban, we have rural areas. So one of the hallmarks is that COVID is a very hyper-local phenomenon. In some places, it's a bigger problem than others. But if you look at statewide, we certainly are in a situation that's very similar to what John just presented. Really, I would say low rates of hospitalizations, still very much there. They're not gone. I see these patients and I see them in clinic, and they come and see me after they've been hospitalized. So they're still there, but really far, far fewer than in the past. I'd also add that it's a little bit, if you look at the state of Illinois, the southern part of Illinois now is having a higher risk area than the northern part of Illinois. And so there's these regional differences that vary. So I think one of the big lessons learned here is that, you got to really talk with the public health officials about what they're seeing, their trends, and getting local data is important in order to make some, informed decisions about what is reasonable and not reasonable to be doing. And what's happening in New York City, it may or may not be relevant to Chicago, may or may not be relevant to Peoria in Illinois. But I think all of those are relevant. And we fortunately have I would say, public health departments that are working super hard in order to stay informed. And so this is a grand testament, I would say, to the need for the United States to support and sustain our public health infrastructure, because it's in examples like this where you realize, boy, you really do need their help. The other thing I'll say in Illinois is we're viewing this as an example of what could go wrong with global pandemics. Most of us think this is probably going to happen again at some other point. Hard to predict when. So a lot of thinking now about what are the big lessons learned, how do we prepare, for the next one. And so I look forward to that part of the conversation.
Yeah, we definitely should come into this, like, how are we prepared for the next one? I want to stick with a little bit of this reflective moments on maybe some specific things, in particular, what had been a little bit of a lightning rod issue for many regions and localities and states was the idea of mask and masking. And we know not only has our understanding of the value of masks changed and how they can be used and where they should be used, and that masks work to help prevent that spread of the disease or the virus. We also know that there's been some question and research into understanding whether a mask mandate was the most effective way to get people to wear masks and to slow the virus of the spread. So I'm wondering if, John, I'll start with you a little bit on this and see if others want to comment about the role and shifting evolution of how we've learned the role of using masks as a way to help prevent the spread. And yet maybe this behavioral thing about a mask mandate, and was that a good tool in our toolbox to use, where there's some learnings from that, some opportunities, some missteps. Let's just kind of talk about the mask one a little bit.
Okay, and I think there's a few things we can say with certainty. So masks, and I'm going to group under masks the sort of medical masks that people wear and sort of official barrier face coverings, but then also what are respirators, N95, KN95, that are designed to protect people from inhaling small particles. So what I'll refer to as masks, using the loose terminology, certainly help to prevent the immediate spread of droplets, cut down on some of the aerosols that we all spray out. I'm doing that right now, except they're going on my computer rather than on a neighbor, but I'm generating millions of little particles just by talking, and they can be infectious, of course. So there's no doubt, and it's proved physically, that these masks and respirators reduced what is coming through from what we exhale into the air around us. The N95, KN95 provide protection for us. And again, if you're in circumstances like travel where you want to take steps that are certainly no regrets to protect yourself, I would advise using a true respirator, an N95 for example. Then you come to the question of, does mandating use of masks make a difference? So I'll make one point first, and I think this is some of the basis of confusion. It's very hard to evaluate and say, did a mask mandate make a difference? Because there's so many other things going on. That said, there have been some good studies. There was a paper on school mask mandates in the New England Journal of Medicine within the year that showed that several communities that continued mask mandates when others dropped them did better. There's some other data. There's been a lot of controversy recently because of a review of the evidence published by a prestigious group called Cochrane. And this review was really misinterpreted and misrepresented. It didn't really shed light on the critical question, did mask mandates make a difference during our COVID-19 pandemic? And so again, without sort of crystal clear evidence and some misrepresentation and misinterpretation, I'm afraid that the question of mask mandates has just become clouded and, of course, politicized, which just adds to the difficulty of sorting out the science.
Any other thoughts on masks?
Sure, I'll wade into this complex pool here. I think fundamentally this is about protecting yourself and also protecting others. And when we had a situation where there was a lot of uncertainty about how dangerous was this virus, how was it spread, what do we need to do about it, I think appropriately public health officials took on a very conservative posture, which is really keeping safe. And if you did have COVID, wearing a mask so you wouldn't be spreading it around. And I think, in many instances, I think it makes sense to have a standard process by which we as a nation, we as a community are being given best practices. And for example, in our hospital, there was a mask mandate. In fact, I still have a mask mandate. When I am in my pulmonary clinic, I have to wear a mask. No matter what. If the patient's coming in with leg pain, I have to wear a mask because, who knows, they may also have some other respiratory illness, not only COVID, but influenza or anything else. So in clinical settings where there's certainly concern and potentially high risk of individuals who may be ill with respiratory conditions, including COVID, we still in hospitals have to wear masks. Now, if you look outside our hospital, even within our university, if you're in an office setting where there's no patient traffic, we don't have to wear masks at this point because we're in a situation where most of us, or nearly all of us, are vaccinated. The virus has also changed. We have a certain amount of immune protection at this point, even if we were to get sick. So I think the way to think about this is that at different points in time, it makes sense to have a standard policy by which we as a society want to protect ourselves. And then as we learn more and as we become, let's say, safe in an environment where you might be sick, then maybe we have to rethink it and relax those policies. So I think it's not really a yes, no. I think it's sort of at that time, did it make sense? And I guess I'm on the side of public health. I'm on the side of protecting people from me and me also being protected from others. So I'm certainly pro-mask sort of individual. So I will then turn it over now to Rachel to see what she'd like to add.
Yeah, no, I think you summed it up nicely. I really was just going to say that I think it depends on the time and place. I think there are times and places now where masks still make sense for individuals that are at higher risk, or if you know you're going to be in contact with those individuals, masks make sense. I think also thinking about back to the late fall when we had not just COVID-19 circulating, but RSV and influenza as well, thinking about masks in those settings for other potential infectious diseases that are being transmitted. So again, I think it comes back to the time and place and what I said at the very beginning about the response and the tools in our toolbox really evolving over time and being different at different periods in time.
Mm-hmm. This makes me think about, again, you have public behavior and the idea of communication and how you can have both coordinated communication efforts that are really clear and transparent, and sometimes a highly politicized world in a way that, this is what we know at the time, and this is the best steps that we can take, and this may evolve and change over time. And how do we as a society and behavior change that and evolve that behavior when we know that's really hard to kind of shift and change, large populations of human behavior over time. And some of that comes down obviously of who's the messenger, how we're communicating, how we're getting those messages out there with those caveats or those nuances or those ability of putting uncertainty boundaries around things so that it becomes a little bit of that more nuanced approach. I'm curious, we've had audience members who always love to talk about this like communication aspect. What have we as a field of public health, and I'm not a we, so you all, but as a field of public health, what have we learned about some of those really useful communication measures? And perhaps like either whether it's a lesson, whether there's a personal story anecdote where like that wasn't the best thing that I or my institution did, any sort of good lessons learned that you think we should all be paying attention to as we move forward. And I'm going to look to anyone who wants to start. Dr. Krishnan.
Sure, happy to. So I think, again, this is all about, I would say, as the most transparency possible about the uncertainty that we face at any given time when making decisions. And I think the more we can be clear about what we know and don't know, and then our motivations for making recommendations for particular policies, both the pros and cons, I think that the better off, we're going to be. So part of it is the message. What is it you're saying? Are you being clear and recognizing there's an upside and downside to any particular policy or recommendation? So one is the message. The second, I think, and this has been a really, I would say, a difficult lesson to learn, is that we're living in a time now where there's a lot of criticism and I would say politicization of science, about facts. There are different people sharing different sets of facts. We don't have a common pool of facts. I think social media has been challenging because people are sort of in their own echo chamber listening to a subset of facts, if you will, and being reinforced. So one is the message. The second is, I think, given the fragmentation and the segmentation of our population, I would think another one is really to say who the messenger is as important as what the message is. So I think we need to be very thoughtful moving forward about having appropriate trusted messengers in different communities. And when I mean community, I don't mean just, zip code. I mean, all of us live in our own bubble of social interactions. So we need to be thoughtful about ensuring we have trusted messengers as well. And then the third is just recognizing that what we learn changes over time, and to have an explicit sort of statement that we're going to come back and revisit this together. And so having a periodic update, if you will, that allows people to recognize that this is not a one-size-fits-all forever, but this is, at this point, this is what we're saying. So in summary, what we say, I think being a little more comprehensive about the pros and cons and the uncertainty and why we're making a decision a certain way, really investing in trusted messengers of various types. And then the third, recognizing that as something like a pandemic unfolds, things change, and you're going to have to revisit it based on all the things that are changing.
So I'll make a few comments. I think if everybody remembers March 13th, I think we all dashed out to the grocery store and bought food and toilet paper. And when you brought your groceries home, you might have been washing them down or letting them sit for a day or two to decolonize. And, we had this idea that perhaps fomite transmission, surface transmission was really important. I'm not sure why we got it so wrong for so long, because clearly with this explosive pandemic, airborne transmission had to be critical to the story. I chaired a committee at the National Academies on providing respiratory protection to the nation. And we emphasized a couple things. And at the bottom was getting the right device into the hands of people when they needed it, with information about how to use it. And that's a goal we haven't met yet. And I'm afraid our report calls for so much to be done by, our country, that perhaps we will never build the frameworks until we start scrambling again if we face another pandemic or some other factor, some other exposure for which we need protection. So I think what Jerry said is key. We have to reach to all the different groups. We have to have the protection they need. Children, for example, we still really lack what we should have. And the idea of being able to communicate with everybody, regardless of education, language, or anything else, is something we haven't achieved yet. A key lesson learned about one thing that went wrong with a fundamental public health measure was we just weren't prepared to get it out there for everyone and to communicate it about it. And I think we need to be, more ready for the next time. And that's the kind of preparedness we should be working on now.
I would just add from the state perspective that communication was central to the response. In public health, we see risk communication as a public health intervention. So just along the lines of providing vaccine, providing testing, providing information to the public is a public health intervention, so that people have the information that they need to make decisions for themselves and their families. And so in my role as the state epidemiologist, one of my jobs was to try and translate some of the data and science, what we were observing in our data, and help people understand it. And so you saw me with the governor and in various press conferences trying to deliver that data in a way that hopefully was a way that the public could consume that data and make decisions for themselves. And certainly we didn't do that perfectly, but I think our goal was really transparency and ensuring that people had all of the same information that we had access to, that we were using to make decisions, whether that was in the governor's office or at CDPHE.
If I could jump in, I think just to kind of build on this, the communication is something that certainly in my training was not high up there. I don't think I ever took a formal class in communication, yet I see patients every day. I communicate to various groups. I'm here on your show today. I've been in newspapers and I've been on TV shows, et cetera. So I think part of this is maybe all of us in healthcare or perhaps with roles or responsibilities for public health, may need to think very seriously about the science of communication, and are we really using, all that we know, and it's maybe just a little bit of humility that it's more complicated than it seems when you communicate. That's point one. Is are there best practices that we should be learning from? The second is that again, this may sound obvious, but communication is not a broadcast. So we have to think a little bit about a bidirectionality of communication. So when we do talk about things, what is the format in which it is delivered? And is there an opportunity for reciprocity? So there's some exchange of information. So you're also sensing what people are taking away from that conversation. And how might you engage in a dialogue? That's a little different than having sort of an advisory, a statement for 30 minutes or a minute, and then you move on. We have no idea whether that was received and how it was interpreted and how it's being acted on. And so it's sort of, these are the things that maybe we need to rethink here is when we say communication, what do we mean by that? And how do we know it's working? And how do we tailor it to the various communities that exist? And I'd be curious what John or Rachel or others have to say about that.
Yeah, absolutely. I mean, you mentioned earlier that the messenger matters, and that's absolutely critical. And I think was a focus of our health equity work during the response was identifying community champions. And we had a program actually of community champions that we identified across the state to do outreach within their community. So trusted voices that had relationships with people, and that obviously makes a big difference when you have someone that is sharing information that has a similar life perspective that you do. So I think that is a critical part of the response, and honestly, I think is something that we continue to employ. I think our most recent response is our MPOX response, where we were responding to a new emerging infectious disease, monkeypox or MPOX, and we took lessons learned from the COVID response and very quickly engaged the LGBTQ community in developing our outreach materials and speaking to the community. And I think that made an incredible difference.
Let me pick up on two of those themes, and John, maybe you can start or others, but the idea here of, you mentioned some of the health equity work, Dr. Herlihy, that's been happening. And I do think that's been hopefully an important reflection and change in perhaps many of both our policies and the field of medicine, which is thinking about what does equity mean in some of our response and some of these disproportionate impacts. And you were talking about, how do you find those health champions and communicators that can help you connect with those communities that someone such as yourself or others may not have a relationship and connection with. So how has that changed and shifted when we've thought about some of that disproportionate impacts that we've seen? Like, where are we learning from that, and are we changing how we do business in certain ways?
Yeah, so I would say that, we've certainly had a focus on health equity, and health inequities or disparities are long-standing issues. But I think one of the things that the pandemic did was really shine a light on some of these problems and probably engage more people in broader conversations about the need to address inequities, long-standing inequities in our response activities. And as I mentioned, I think one of our more recent successes is doing that very early on in the response to MPOX, engaging our community and having those conversations, because we don't all have the same life experiences and lived experiences to understand how messages are going to be perceived by different communities. And so I think that has been something that has been elevated during the response, and hopefully will be something that continues, that engagement with the community, that outreach work. In our division at CDPHE, we have a new health equity group within our division that we work closely with and engage with when preparing our responses or engaging the community and trying to understand the impact of various infectious diseases.
I'll just comment, if you look across the course of the pandemic in Colorado, the rates of hospitalization across the course stayed lowest in those individuals identified as white, and those identified as Asians were even lower, while other groups, Black, Hispanic, and American Indian, remained at the top, and sort of fluctuation as to which group was at the top. And there are many reasons underlying that, including how much people are exposed. There were certain occupations where people did not go home. They, in fact, stayed public facing and were exposed more than others. Those individuals in the service industry and grocery stores and maintaining transportation. So the impact of exposure was different, and then the distribution of those conditions, which makes people more at risk for more severe disease, also varied, as did healthcare access. So, there's a lot of complexities here to sort out in terms of trying to do better next time. And I think there's some clear lessons learned and lots of academic writing about these problems. Now we need to go on to the solutions.
Let me bring in another comment that you both had talked about and expand a little bit further. Dr. Herlihy, you were talking about MPOX. I'm curious, Dr. Krishnan, maybe you can elaborate how some of our response to COVID-19 has informed the public perception and response of how we're dealing with potentially other emerging diseases and viruses. Let's go to kind of that big theme. Like, what are we learning here, and how is this applying both in the field, but also I think in the public perception as well?
Yeah, Rachel, you want to go first?
Sure. Yeah, I think one of the things that I have noticed since, probably mostly in the last year or so, as public interest and media interest in COVID specifically has started to decline, I have noticed much greater interest than I recall pre-pandemic in infectious diseases. So lots of questions. I think the public, the media understand infectious diseases and how they're transmitted, and perhaps are more curious than they've been historically. But that's definitely a big difference that I've seen, is that the general population and the media seem much more interested in the work that we do now. And hopefully that's a good thing in understanding how diseases are transmitted and prevented, and in being engaged in the response with us. But definitely a substantial shift that I've noticed in the last couple of years.
Yeah, I'd like to add to that. I think the other sort of complement to this is, I think, a greater recognition that infectious diseases have a so-called acute phase, when you get initially sick or infected with something, and then what's called a post-acute phase, or sort of the chronic phase, or the subsequent weeks, months, or years afterwards, which at least in the COVID context is being called long COVID, in the lay community. In the scientific community, sometimes it's called post-COVID or post-acute sequelae of SARS-CoV-2, or PASC. There are a lot of terms being thrown around right now. But I think this recognition that infectious disease, in some cases, actually has a tail, and that tail can be almost as bad or even worse in some cases than the acute infection. So I think we're really starting to recognize that. For example, people I'm sure are aware that polio, polio had an acute phase where you might get sick, you may have some GI symptoms, but some people then went on to have paralysis, couldn't breathe, and so forth. So there's this tail, if you will, that became actually the real problem with polio. It wasn't literally the first parts of the infection. Lyme disease is another example, a tick-borne disease that I'm sure folks in Colorado are well aware of. And so there, you may get a rash, or you may have some, acute symptoms, but then some people go on to develop neurologic problems or cardiac problems or other arthritis or other issues. So I think long COVID is going to be with us, so to speak, or PASC, as the scientists would like to call it. And that's probably an important topic for your listeners as well. I don't know, is this a good time to get into that?
Yeah, I think this is a perfect time for us to talk a little bit about what is long COVID and what do we mean by that, and give a little explanation and continue on. I think you have a slide that we want to share showing. Yes, please continue.
Perfect. Yeah, thank you, Krishnan. So this is a slide from the U.S. Centers and Disease Control. It came out in May of last year. And this probably represents the best data literally in the world, I would say, about what we're calling long COVID. So let me first provide a definition of it, and then we'll go through the slide. So long COVID is essentially symptoms, signs, or conditions that exist, at some time period after the original illness. And sometimes people use 1 month after the original illness. Some people use 3 months, some people use 6 months. That's under some debate right now. When does that clock actually start for calling it long COVID? So the U.S. Centers for Disease Control did a really a historic study. This is data from 2 million Americans in 50 states, where they looked at electronic health records of people who did or did not have COVID, and then followed them for about a year in the electronic health records, again, across the US, to say, what are the conditions that seem to be popping up more in those individuals that had COVID versus those individuals who did not have COVID? And sort of the top line summary of all of this is on the left-hand side of the slide, is that about 1 in 5 adults, or 20%, so out of 100 people, 20 people, if you will, age 18 or above, have at least one more condition than they would have otherwise had they not had COVID. Again, this is observational data. This is using what's in the electronic health records. It's the best estimate, right now that we have. And then if you look at what are the conditions that perhaps light up as being, one of those extra conditions, if you will. First is that some people have multiple conditions, not just one, but if you were to list the universe of the most common conditions, they seem to be essentially any condition. They looked at 26 conditions and all 26 of them lit up. And it could be problems with the heart, or what we're calling cardiovascular conditions, fast heart rates or dizziness when you stand up, something we call postural orthostatic tachycardia syndrome. Or you could have respiratory conditions. Could be cough, could be shortness of breath, could be some vague sort of chest discomfort of some kind. Some people have blood clots, particularly early in the disease. That's a little bit less common now that we've seen this, much later, but certainly blood clots early after having an illness is more common. Musculoskeletal conditions such as just weakness or joint pain, kidney problems, and then probably I would say, worrisomely in some cases, just neurologic and mental health conditions. So I'm sure people have heard of brain fog, the inability to concentrate, perhaps difficulty, looking at bright lights or a television monitor, and then of course anxiety and depression. So anywhere in which there's blood flow, that part of the body could be affected and could take a long time. It could be even months or years afterwards. What is really also concerning about long COVID or post-COVID conditions, or PASC, depending on how you want to call it, is that although it's more common in people who are hospitalized for COVID, it can also occur in people who have relatively mild disease, which is concerning because it means that we shouldn't just focus on people who had severe COVID. It looks like really pretty much anyone's at risk. And what we're learning is that it's not only the virus, what type of virus variant that may have infected you, but the host response, your immune system's ability to fight the infection and keep it at bay, and whether it appropriately turns off when it's sort of taking care of the infection. And then finally, as John mentioned earlier, how quickly you get care. Do you let your COVID get to the point where it gets serious? So this access to care, or what you go about doing once you get healthcare access. So in summary, long COVID is essentially any condition that happens 1 month or longer after the initial infection, and we now know it can affect any part of the body. And the best data right now is that 1 in 5 adults who've had COVID end up with an extra health problem that we're now calling long COVID.
Thank you for that. John, Rachel, I'd love for you to kind of add on what, how are we managing this? What does this response look like to understanding long COVID?
Yeah, I can start in that, as an epidemiologist, my perspective here would be in trying to understand the scope of long COVID and quantify how much long COVID is occurring. And there are many challenges in doing that. There's a new report out from the governor's office. The Office of Saving People Money on Healthcare here in Colorado has a new report out where we've done some work trying to estimate the burden of long COVID here in Colorado. But honestly, one of the really fundamental challenges, which is now being addressed nationally by the national academies, is trying to define what long COVID is. As you just heard, it is a very wide-ranging number of syndromes that can occur. And so defining it is the first step in trying to quantify and understand the burden that exists right now. And so that's really, I think, one of the challenges in front of public health and trying to understand the problem. And then, of course, next is ensuring that individuals who are experiencing long COVID have access to healthcare, whether that's specialized healthcare or ensuring that their primary care provider knows about long COVID, knows how to diagnose it and how to treat it. And so I think that's a lot of the work that's happening right now, both at specialty healthcare centers for individuals who may have more complex cases, but also just your average internist or family practitioner really needs to have a strong grasp of what long COVID is to identify and treat patients.
I'll just make one comment. So far, long COVID can only be as long as 3 years. And I think what's important is that from the research side, is that we are geared up to continue to watch people at risk and understand what happens. And for those who have it now, to understand what its natural history is going to be. I know Jerry's involved in studies that are addressing this kind of question. So we're just at the start. And I think we need to make sure that we're watching carefully to see what happens.
Yeah, thanks, John. And Rachel, I obviously agree with your comments. I'll add a couple other comments as someone who sees patients with long COVID. Is that I think the first is to validate the fact that there are some people that have not fully recovered or perhaps have new problems that they didn't have before. So at the beginning of this, nobody even knew the potential for long COVID. So I think I suspect a lot of people were not believed, either by themselves or their family members or by their doctors. I think so. The first is just to acknowledge there's a lot we don't know, but we do understand, and there is now good information suggesting that this is a problem. It's a multi-system problem, and it does exist. So we're kind of in the descriptive components right now, counting up how many of these cases exist, how do you define it, and so forth. The other sort of component of this, and I think people should be encouraged by this, is that the federal government has put a substantial amount of resources at play in funding what's called the National Institutes of Health Recover Initiative. And it's a $1 billion program. It's the largest study that I've seen in 25 years in academia, where they have literally, coast to coast in the US, including, by the way, 2 centers in Denver, both Denver Health and the University of Colorado are part of this recovery initiative, where we're not only counting and categorizing and describing it, but we're studying the biology of it. Sometimes we call it pathogenesis, what's actually going on that's creating this problem. So there's some serious scientific effort in a coordinated way across the country. First time I've seen this, actually, that it's coast to coast. We're all running the same study protocol, and we're studying this in a very rigorous, systematic way. So that's the first thing, is we're counting it. We're certainly putting a lot of energy in understanding the biology. And the third, and I think people will start hearing this soon, is in the next couple of months, I would say, you're going to start hearing about clinical trials for long COVID. So for people who are affected by it, that there's going to be opportunities to determine if you'd like to volunteer for studies testing different treatments. The reason I'm bringing this up is right now, if you go on the internet, you can find all kinds of home remedies and sometimes not so much home remedies, things you have to pay a lot of money for. I'm not so sure whether I'd try some of those things because they seem a little odd and don't really quite know how legitimate or credible, the people who are proposing all these are. But I would say once these recover clinical trials start, I would suggest that that's the opportunity for the public at large to feel that there's now a path forward about how to actually learn what does work, and just as importantly, what doesn't work. So we shouldn't be wasting our time with it.
Thank you for that. We've got about 10 minutes left here. I want to bring in a few more audience questions and try to cover a little bit of ground here in the last 10 minutes. Mark, brought up a really thoughtful comment and question about how at the beginning of the pandemic, we didn't see some critical failures in surveillance and testing and availability of PPE, not only for healthcare workers, but also for the general public at large. Have we resolved some of this? How are that sort of like almost supply chain response capacity really geared up for potentially addressing these issues in the future? Rachel, do you want to maybe start talking a little bit about that, and obviously others' ideas too?
Yeah, so my perspective would probably be more around the lines of how we've changed our data infrastructure and our ability to collect data, and that has changed dramatically. Thankfully, with an influx of federal resources, we've been able to redesign our surveillance systems. We're actually in the process of doing some of that work now. So if you think back before the pandemic to the types of communicable diseases that our team was investigating, they didn't happen on the scale of tens of thousands of cases. They were much smaller numbers. And so we really didn't have the data infrastructure to receive the large number, the volume of cases that we were seeing and process that data. And so that has certainly dramatically changed over time. And then I would say the same thing for our state public health laboratory also. Their capacity has dramatically changed over time, from the scale of running single digit number of tests in a day to being able to perform thousands of tests. So dramatic change in infrastructure, and we're certainly hopeful that investment in public health is going to continue into the future. But one of the things that we've experienced with public health emergencies in the past is these large sums of funding that come to public health, but they're often siloed funding. They're specific to a given disease. And then we see resolution of that disease, but then we have a new emerging infection that comes up, Mpox or a new type of influenza or whatever it might be. And those dollars that public health has received are very siloed and unfortunately can't be used broadly. And so a lot of work, I think, has gone into improving public health infrastructure, but that work needs to continue and needs to be less categorical than it has been historically, because I think, unfortunately, public health has been underfunded for decades and decades. And I think that that was unfortunately apparent at the beginning of the pandemic for our ability to scale rapidly.
I'll just make one comment. I mean, I think we both need to do better on the preparedness side, but we need to rebuild. And I think both have to go on. And of course, both take funding. And again, there's various task forces and reports calling for transformations, a lot of emphasis on data, and Rachel already commented on the response there. I think we need to have a longer term view than we usually have after this kind of circumstance. And let's just hope that that happens.
What about monitoring of other emerging zoonotic diseases? Is monitoring being effectively done? Have we seen an increase in that? I'd be curious.
Yeah, so honestly, even before the pandemic, there was an increasing emphasis on something we call One Health, which is this recognition that animal health and human health are very intertwined. We know that a number of emerging infectious diseases can emerge out of animal populations. It's the classic model for influenza that we think about. Lots of us have seen lots of reports about avian influenza in the news recently. And so certainly investing in that public health infrastructure that lives at that interface between animals and humans is critically important for us to be able to detect emerging infectious diseases early and respond to them. And recognizing that animal health, ensuring that animals are healthy is critical for ensuring human health as well.
And I just point out, this is an in-strength state at CSU, which has a vet school, of course, and One Health initiative.
Great. I want all of you, if you don't mind, taking on this kind of final question, whether that is a personal reflection of yourself or a reflection on the public health field at large, which ties a little bit into this idea of trust and trust in public health and medicine, which we have seen has taken a beating, and whether it's been politically, loss of trust based on political divides or whatever sort of factors could play into that. And I'm curious whether you personally or as a field have had any reflections on where there has been a misstep and an opportunity for personal learning and growth as a field or as an individually, because we know there has been some harm done in that trust, and the idea of needing to rebuild some of that I think is important. So maybe perhaps in our last few minutes here, if you all want to take a moment to think about that idea of public trust in public health. I'm going to let someone smile and nod and start the conversation for me.
Jerry, go for it.
Sure, I can start. I think that as a university, we're thinking more broadly about our role in the ecosystem of trust. I think recognizing that most difficult things that have happened with COVID have moved at the speed of trust. And that this is probably not the last time we're going to see some version of this. So we've put a little more, I would say a lot more energy on building community partnerships, really having a reciprocal relationship where we're bringing value in a bi-directional way, involving them more in our activities, spending some time outside of university walls, and really thinking more about a relationship building activity more broadly, because we don't know when the next issue is going to be or what specific problem it is. But if you already have a relationship to build off of, you're going to be that much further ahead.
Well, I'll break the pause here. And, you know, I have to say, as someone who trains people and done this for decades, who will go out and do research in public health, practice in public health, lead policy in public health, I think this is really important that trust in this field and other fields of science has been eroded. I mean, the Institute of Science and Policy has part of its purpose is sort of directed at assuring trust in science and what we know. I think we face a new challenge, and it's, I think, ever more acute. That is the rapid spread of incorrect, misleading, and potentially harmful information that has really threatened some basics of public health. And I think for those of us in public health, we need to understand how to deal. I'll sort of analogize with the threat of emerging viral misinformation, and how do we contend with it. And certainly COVID-19 is not the only example of this being a problem. So we have those who are deliberately disseminating wrong information. Let's call that disinformation. And sometimes with pretty base motivations, like selling a product that doesn't work, or some other sort of self-gain. We need in public health to know how to deal with that. I think for those who have politicized public health and have chosen to attack public health measures or public health personnel for their own gain, that's unfortunate. And it has consequences that have been realized. They can be demonstrated in mortality figures. So I think we have work to do there. And I think that does go back to learning how to communicate perhaps more powerfully and communicating at the right time. And those who do so, you know, do face, it's risky. It's a risky business. It takes work. And there may be counters, but I think it's important to continue to place what we know in front of the public and admit what we don't know.
Yeah, I think for me, you know, obviously our goal has been to be transparent since the beginning of the pandemic. And for me, that was in sharing data and information for individuals to make decisions. But when it comes to lack of trust, I mean, I think there's probably a lot of work for our academic partners to do to understand where that lack of trust is coming from. There's certainly things that we recognize and we know we need to work on, some of the health equity work that I mentioned. But I think there's also a lot we don't know about where lack of trust in government or public health is coming from. And so I think there's a lot of work in front of our public health academic partners to try and understand that and help us be prepared in the future.
Well, thank you. I do want to say, you know, both John, Rachel, and Jerry, I just want to say thank you, obviously, for your service, your dedication, and your leadership, as well as to the entire field of public health. We definitely appreciate all that work that you all have given, a lot of blood, sweat, and tears for getting us through this pandemic as far as we are thus far. And thank you for being with me today and sharing some of your thoughts and reflections. I do think taking some of those critical hard looks is always a great way of how we learn to move forward. So thank you for spending this time, an hour with me. I found it extremely helpful. I learned a ton. I hope our audience did as well. And if you learned something, obviously, today, please take that and share that with a friend or even a stranger, and help kind of, you know, be that trusted messenger of help sharing good information, hopefully. Thank you all so much for being here today.
Thank you.
Thank you. Bye all.
Thank
Bye-bye.
you all. There. We'll have links to our recordings dropped here into the chat. Visit institute.dmns.org if you want to find out where this video recording is or save today in any of our work. Thank you all. Take care. Stay well, and we'll hope to see you next time. Bye.